Okay, folks, welcome. Why don't we go ahead and get started? I want to welcome all of you, in particular those who are coming from the community. Feel free to leave your email address so that we can make sure you know about future events. I see a lot of our PhD students, so thank you for making the time on this rainy day. I know you've all got a lot going on, but I also know Dr. Mayorga has some really interesting things to say, so you've made a good choice. I want for the students enrolled in the seminar for credit to just take a few moments for you. First of all, thanks to all of those of you who came to the symposium last week. And I hope you were able to see some interesting work and get some exciting ideas. A couple of reminders about course administration. First of all, there's pre-reading that you should be doing before the class every week, and then you should be working with your partners to prepare the material that's basically sort of combining your thoughts on the reading, your thoughts on the talk, your ideas from your own experience. There's been some ambiguity, actually it's just complete contradiction, so we've said different things in different places. We're going to err on the most generous, which is the writing assignment will be due at 4 o'clock the Monday after the talk. And we realized that some of you were having trouble. If you couldn't meet right after class with your partners, sometimes being able to get everything done by Wednesday was a problem. So the writing assignment will be due at 4 o'clock the Monday after class. If the writing assignment is turned in late, you have 24 hours and you lose a point. And given that it's on a scale of 1 to 3, and 2 is basically an A score, 1 actually drops you a lot. So you should be working with your partners. If you're not working with your partners, it's not an option to say, oh, I'm really busy this week, I'm just going to do it on my own. It is a joint effort. You both get the same grade. If you're having trouble finding your partner, let us know. Sometimes people drop the course early in the semester, and so we'll coordinate that. A reminder about your index cards. So the index cards serve two purposes. One, they're your attendance for the lecture. The other is, we know that sometimes some of you are a little shy asking questions. Hopefully that will ease up over the semester. But in case you are, we still want to give you the opportunity. So the expectation is that when Andrea and I start walking around towards the tail end of the talk discreetly, you'll be handing them down. Our walking around is not your cue to think up a question and write it down. Your writing should be done before we stand up. It's really disruptive to the speaker if suddenly everyone's scribbling. So as the talk is going on and you think, that's interesting, I want to make sure I remember to ask that at the end. That's when you should be writing it down. And with that, let's go ahead and get started. I'm very, very happy to welcome a friend and colleague, Dr. Maria Mayorga, who actually spent some time here at Michigan a few years ago and hopefully enjoyed her time back in Ann Arbor. Dr. Mayorga is a professor of personalized medicine in the Department of Industrial and Systems Engineering at North Carolina State University. Her master's and PhD in industrial engineering operations research are from UC Berkeley. Her research interests include predictive models in healthcare, healthcare operations management, emergency response, and humanitarian logistics. She received the Distinguished NSF Career Award for her work to incorporate patient choice into predictive models of health outcomes, and we're very happy to have her back in Ann Arbor. Thank you, Maria.
All right, I'm going to try not to use the mic, but I think the room is small enough where, can you hear me? Okay, good. If you can't hear me, just wave. And I'll try to speak up. So my name is Maria Mayorga, and the title I have is Professor of Personalized Medicine. So I want to talk a little bit about that. Actually, we changed the name of the cluster recently to Precision Medicine, Personalized Precision. Depends on who you talk to. As many of you know, precision medicine is basically about giving the right treatment to the right person at the right time, using individual level information to inform your decisions. So at NC State, it's a cluster, which means it's a group of faculty. It's not a specific space. And we're in the Statistics, Math, and Industrial and Systems Engineering department. And so what we bring to the table is more about developing quantitative methods to enable precision medicine. Of course, since we don't have a medical school, we partner with medical schools at UNC, Duke, and other places, for example. So the work I will present today is in partnership with other schools, and I will talk about who the partners are. So I just wanted to kind of explain the title that I have, since maybe it's a little bit unusual. So, as Dr. Cohn said, my interests broadly lie in modeling systems under uncertainty in order to make decisions. And I started when I was in graduate school, not really focused on healthcare, more on retail and logistics, but there the emphasis had always been on how do we account for heterogeneous consumers. In this case, we're talking about patients. Everybody is unique. So you may not respond in the same way to the treatment or the intervention. But what I like to focus on now is not just using using these research tools to look at policy level decisions. So not just individual level treatment, but decisions that can have broad impact with a specific focus on reducing health disparities or inequalities in healthcare. I do have research also in resource allocation in emergency and disaster situations. For your 911 systems, for example, but also in humanitarian logistics. But today, being at the Center for Healthcare here, I'm going to speak about my work related to predictive models of health and economic outcomes. Okay, so I'll kind of talk a lot about some of my other research areas too, and then I'll start with the talk for today. In these predictive models of health outcomes, what I like to do is use multiple sources of information, data, wherever I can get my hands on it, to inform and different methods to predict health outcomes at levels for which we cannot actually do in practice, right? It would be very costly to do a very long longitudinal study, or some interventions are not things you actually want to test on individuals. Today I'm going to be presenting about colorectal cancer. I have work related to the weighting is it doesn't show up, but the little skeleton there is related to a patient waiting on for a transplant, for example, and they're getting sicker as they're waiting for a transplant. Work on smoking cessation interventions, and most recently, and I'll talk a little bit about that in the end as well, on sepsis, on how can we predict sepsis, which is a systemic infection of the blood earlier. It's a very hard to diagnose disease. Today, I'm going to be talking about the impact of insurance expansion on colorectal cancer screening. So you might be asking yourself, wait, you just talked about precision medicine. You just talked about the individual. And now you're talking about insurance expansion, which is a broad intervention at the population level. Well, the thing is that when we come up with these broad interventions, they have differential impact on individuals, which can impact how the population responds to it. So oftentimes when you see population level estimates, they don't actually consider at the individual level, they look at averages. And so I'm going to be modeling individuals and then aggregating this to see what the impact is at the population level. So like I said, I'm not an expert on colorectal cancer, so of course we work with both MDs at UNC. I don't actually have Mike Piñones' picture there, who was an MD, but also people who are in cancer research. So the funding is from the NC-CRC, and then the collaborators are at UNC. I'm going to focus on North Carolina, but I'll talk a little bit about Oregon because we're now starting to model Oregon, and so we work with the Oregon Health and Sciences University to do that. And these are my students. Rachel is now at CNA, which is a naval research, naval health research work, and then Sid is the current PhD student on the project. Okay, so why colorectal cancer? Actually, colorectal cancer is the second leading cause of death by cancer in the United States, with the #1 being lung cancer. So a lot of you, have probably heard about breast cancer and prostate cancer, and even though those might be prevalent, colon cancer is quite deadly. So it's something that we want to reduce the burden of that disease. So how can we do that? These numbers are from 2015. I'm thinking they're going to look similar. But if you can see the picture, if we happen to catch colorectal cancer early in stage 1, it has a very high survival rate. Compare that to if you find it at stage 4, you have a survival rate of 11%. So in this case, the key is screening. So the recommendation for colorectal cancer screening is for adults ages 50 to 75 to have a screen. And the screen, there's several different options. The two most common are colonoscopy. Colonoscopy is something where you actually have to go to the hospital, and you have to have anesthesia. You have to have somebody that's going to be able to drive you home. But if you have that, there's two positive sides to that. The colonoscopy, in addition to being a screening test, is also a treatment. So if they find a polyp inside, at that point they can go ahead and remove it, and so they can remove the cancer. They can remove the polyp, which can become cancerous, and also it's good for 10 years because it's because the polyps don't grow that fast. So if they've already done a full colonoscopy and they didn't find anything, you don't have to have another test for 10 years. But it's quite invasive, and I'm not going to go into the details, but you can imagine a colonoscopy is not like something fun that people want to get. So the other option is a fecal test, and that is actually something you can even do at home. They mail you a kit, you put a stool sample in there, you send it away for testing. The problem with that is that you have to do it every year to really stay up to date with screening. And if they find something, then you have to go and get a colonoscopy. So the recommendations are for 50 to 75-year-olds to be up to date with screening. That means either a colonoscopy within the last 10 years or a fecal test within the last year. And there's other modes, but we found in the data that less than 2% of the population was using some of the other screening modes, like sigmoidoscopy. So in this study, we're not focusing on coming up with a new treatment or coming up with new recommendations of when people should screen. So you may have seen those models before, right? Well, let's come up with a new treatment, or let's optimize the screening timeline. The screening is known to work. There's been lots of studies that show that if people follow the recommendations, then we really reduce the incidence of CRC and mortality, and it's cost effective. So what do you think the problem is? Why do I have something to talk about if we already know what to do and we know when to do it? Yeah. People aren't getting colonoscopy. I mean, who wants to get a colonoscopy, right? So yes, it's very underutilized. Only, these are from different sources, but only 62% of people were found to be up to date in 2015. 27% had never screened. And that's, you know, if you look on the surface, that might, the bigger issue is that the screening rates are differential. By population. So younger adults are less likely, younger in the 50 to 75 window, right? So 50 to 64-year-olds are less likely to screen. Ethnicity, so Latinos are less likely to screen. People living in poverty, those without a high school education, people living in rural areas. There's all of these things that impact whether or not you screen, right? Or, so why might that be? One is costly. Right, potentially. One is, if you have a lot of other problems, you're not really thinking about what I could get in the future, right? You have a lot of current issues to deal with. So we want to take into account what individuals do, but one of the biggest determinants of screening is actually insurance. So whether or not you have insurance is makes a huge difference, right? Because, well, who's going to pay for a colonoscopy? They're quite expensive, or even the fit kits are only like $20, but it still costs something. And if you don't see a provider regularly, they're not going to recommend it to you. So if you don't regularly go to the doctor, then you might not know that you're supposed to be getting screened. And then the publicly insured, that is people on Medicaid and on Medicare, are also less likely to screen than people that have private insurance. So that's where we want to study what the impact is of the Affordable Care Act. So there's a little bit of history of the Affordable Care Act. Some people say Obamacare, but it took effect in the provisions rolled out between 2013 and 2014. So one big thing is the no cost sharing on essential preventative services. Okay, so, well, first of all, everyone had to have some form of insurance, right? Or they would pay the penalty, and every preventative service is covered. So it's zero cost for you to get screened if you're following whatever the recommended guidelines are.
So Maria, just to clarify, the no cost sharing is no cost sharing on the part of the patient, that 100% you can't have a copay. As a patient, you pay zero for anything that's considered essential preventative care, and this would include colonoscopy.
Right. So, but here's the rub on that, because even though the colonoscopy itself is free, if they find something and they have to remove it, now that's treatment. So now people do still have to pay for that, so that might be why they may not want to go get a colonoscopy. Also, you have to be in a comfortable enough place where you can have somebody, you can take a day off work without it causing a problem, right? If you live in poverty, that might be very difficult, and you have to have somebody who's gonna drive you, or drive you home because you're gonna be in anesthesia and you're not gonna be able to drive. So, so there's a caveat. So everyone, ACA was everywhere, and then there's Medicaid expansion. So what is Medicaid expansion? Medicaid expansion, the states that chose to do Medicaid expansion basically lowered, made it easier for people to have Medicaid. So before it had to be like 100% of the federal poverty line, now it's 138% of the federal poverty line, which is actually very, very low income. So, if I click there, you'll see a map. If I send you the presentation, you'll be able to go to the link. So I know Carolina, we did not have Medicaid expansion, and that was one of the questions. What if we had Medicaid expansion? And Oregon did have Medicaid expansion, and I can show you kind of some of the differences of what happened afterwards. I looked up Michigan, and Michigan had Medicaid expansion, but then they wanted to put a caveat in it about cost sharing, and they did get it approved by Congress. So apparently Michigan is a special case where they have some cost sharing for Medicaid patients, but they did enact Medicaid expansion. So they did something different. But I'm not an expert on what Michigan did, but. Okay, so what do we want to know? What is the impact of the Medicaid expansion and the Affordable Care Act on colorectal cancer screening? How does it change people's screening behaviors? And what is the potential impact of changes in screening on long-term outcomes? Okay, so I get more people to screen. Does that actually impact the number of cancers down the road, right? And how many of those? Now, we're going to be predicting something that hasn't happened. That didn't happen. Medicaid expansion didn't happen in North Carolina. So what kind of tool am I going to use to predict what didn't happen? Simulation, right, okay. So we use a simulation model. I call it the NC-CRC simulation model. So it is a mouthful, geospatially explicit, population-based, individual level, discrete event simulation model of the main components, the natural history of cancer progression, colorectal cancer progression, and the layer that's new that nobody else does is screening behavior of individuals. Okay. So in this model, we account for the fact that individuals do not comply or have the same choice of mode, and who they are may drive that decision. We also have a very detailed model. The CDC wanted to know what interventions would work well in the state, so we actually have a synthetic population of North Carolina. That is, we simulate each individual that is age eligible at the time. And in past work, I think I sent 2 papers to you. In the PCD paper, we looked at the cost effectiveness of interventions that the CDC wanted to prioritize over which things we should do. Also beyond that, we now partnered with Oregon to extend the model beyond North Carolina. Yeah.
So are you assuming you have enough resources for this screening?
For the first one, we do cost effectiveness, so we show like for a certain budget how much the impact would be.
I'm thinking of hospitals, doctors, labs.
Yeah, we included the additional impact to the hospital system in terms of the number of colonoscopies, but there wasn't such a huge change in colonoscopies that it made a difference. But yes. We actually found that the distance measure, people reacted very differently to distance. We thought that the further you would be away from a colonoscopy facility, the less likely you would go there. But it was a U-shaped curve because apparently, like, people in rural areas don't really mind driving very fast. I mean, driving very far, maybe fast too, I don't know, but driving very far. And also they tended to try to bundle all their services and go at the same time and kind of get everything taken care of at the hospital. This is the model down here. So a simulation model, that sounds great, right? Well, to me it sounds great, but that sounds great. But how are we gonna populate this model, right? If you get junk in, you get junk out. So we have many components to the model. I don't know how legible this is, but I'll go through each one. First, we have to say who. Who are the people that we're modeling? Then, how are they developing cancer? How does it progress? Then, the part that is very different is how do they screen? And then, how do they react to the interventions? So I'm going to go through each of those individually. So the demography, the people who we're looking at. So we use a synthetic population that was developed using the American Community Survey, the Census Bureau, so it has very detailed information about households. And so for each simulated individual, we have their zip code and also the age, race, income, and household size. So this is created to be to be distributed very similarly to the real population, but then they're not real people, so you don't have to worry about that. The only problem is that there was not an insurance indicator, and insurance is important to us, associated with that. So we use the American Community Survey, a different part of it, to predict the person's insurance type based on the variables that we do know about them. So that's our population. I'll show you exactly which cohort we're simulating. The natural history model. So we model the polyp adenoma process. So you basically have a lesion that can grow into a polyp or adenoma that can grow into a cancer. A person can develop multiple polyps, and they each progress independently. This is differentiated by age, race, and gender. And then depending on the size of the polyp, they may be detectable by the screening test. There's different specificity and sensitivity depending on the size of the polyp. One thing we're not modeling is the location of the polyp, and apparently there is potentially differences in specificity and sensitivity of the test based on the location of the polyp. So that'd be something interesting to look at in the future. And then depending on at what stage the cancer is detected, we have survival curves on the person. We also have a natural the lifespan of an individual without cancer, so that we can look at whether a person can have cancer, but they can still die of natural causes. So we look at whether or not we have these two competing events. Once a person gets cancer, they have a time to die from cancer, and then they have a time to die from natural causes, and they can die of one of those. So the model is coded in AnyLogic, which is Java-based or object-oriented based. So we have these lesions that grow, and the lesions can develop multiple ones in an individual, and then the individual cancer can grow, but then the screening test can detect the lesions, and that's how we can basically change their cancer progression in that manner. I don't necessarily like this picture, but if you all are into programming or object-oriented languages, this might be a way you like to see it. I like to show the natural history model like this. So basically you're fine, you have nothing, and then you may develop a polyp. So the polyp is small and then starts to grow. And then these polyps can turn into preclinical cancer. Preclinical means that they're at this point detectable by screening, but they are not. They haven't been detected yet or diagnosed, and then that clinical stage happens because you either become symptomatic or you get diagnosed. And so from any of those clinical stages, you go to death. So the idea is that before you can't go to death in preclinical because you would become symptomatic, and then you would be staged. Now, there are some people who, once they do an autopsy, they found out that they had cancer and they were never diagnosed with that, for example, but we're not taking that into account. So that's the natural history model. Now, there's a lot of parameters associated with that, right? We have to know the incidence cancer, and this is like the natural progression. But there's not a lot of data that just lets people with cancer just keep going. Let's not treat them. Let's see what happens, right? So we have to calibrate this model based on what data we do have. So we had some previous information from the RTI model was calibrated, but it was calibrated to data from the 1980s. And we know that cancer has changed a lot between the 80s and now. And also it was not race specific, and because we're interested in disparities, then that was not helpful to us. So what we did is we took that model as a starting point. We found some new incidence numbers that are race specific, but they were not yielding the number of cancers that we're seeing. So what we have is data from cancer cases, from actual cancer counts in North Carolina by year. I'm only showing localized here, but it's localized, regional, and distant are the different stages. Total cancer cases, and then you can see by age. So, so you can see that there, so most of the cancers you can see are made up of the older age groups, but there are some cancers in the younger stages. This didn't used to happen. It used to be that you didn't really have to worry about colon cancer until the 40s, but we're starting to see incidence happening in the as early as the 30s now. So we have the rates of cancers, and that's what we calibrate to. So what we do, if I'm going too fast, then let me know. I tend to speak fast. So what we do is we want to calibrate to the cancer incidence rates per year. That is, we create a population so that we can see people that are age 32 to 92 between 2008 and 2014, and we count how many cancers, how many localized cancers did we get, stage 1, how many total cancers did we get, how many cancers did we get in the younger age groups, etc. And we're trying to match those numbers. To do that, what we do is we calculate the root mean squared error between the simulated and actual values of 3 things they felt was important: the distribution of the staging, the stage 1 versus the others. So the regional and distant get mapped to, and the registries also have a category of unknown, which is not that helpful to us. But the local cancers map pretty well to stage 1, so we're trying to match that, the total number of cancer cases, and then the age distribution. So we're trying to match all of those different things. So we vary certain parameters, and then we have constraints on some of the other ones. So given one parameter, we can figure out some of the other ones. I'll show you that in the next slide. Now the problem is that the simulation is very large, so it takes quite a while to run. So, ideally I would take all of these parameters and I would try thousands of them on combinations that are all feasible and find the best one. But we don't actually have the luxury of doing that with the computation time, and then it also, the output kind of kills the memory on it as well, even though we're using a large computer at RENC. So what we do as a stage, we basically calibrate, and these parameters affect different things. So we first find the quality preclinical parameter that leads to the lowest error that I can get by affecting that parameter, and then I fix that one, and I look for the best one in X1, and so on like that. And we're trying to minimize the average error. We have different weights that we could use instead of equal value. They all yield about the same, and so we're able to get to about the same cancer rates as the real population, within 9 cases per 100,000 of the real population by doing this. So here's more of a picture of this. So for example, the first parameter has to do with the rate at which you move from a polyp to a preclinical stage. And then we're varying this one. We have a constraint that says we know the total time that it takes to leave the we know the expected time that it takes to leave the preclinical stage. So once I know the time to leave to clinical stage 1, then Y1 becomes known, and so on. So we do that to calibrate the model to the cancer incidence in North Carolina. Okay. So now we have people, they develop cancer, and now we have to see how they screen. So screening compliance, I mentioned that we saw how many, 60% or something like that of individuals were up to date in that one statistic. So you have a choice, not only of whether, a choice or an action of whether or not you're going to screen, and then if you do screen, which modality you choose. The collaborators believe that people tend to be of one type of person, and they tend to stick to that modality. Though when we got data, we found some contradictory evidence to that, so we were trying to come up with different models. The data that we have are claims data, so this means receipt of screen. We removed people who might get colonoscopy for other reasons. So if you have some GI problems, for example, might be a reason for you to get a colonoscopy. That's not really a screening, that is a service because of another issue that you have. People who are on surveillance for cancer, for example. So we removed those individuals. And then we developed a statistical model to estimate by insurance type what type of screening you would get, and then the chance that you would comply. So you can't see these numbers. The point is we start with a lot of over 3 million claims records of both Medicaid and a commercial, the largest commercial insurer in North Carolina. And once we start to exclude people for different reasons, we end up with a lot less, right? So we have only 4,000 claims records in Medicaid and 60,000 in the private insurance. So we have a lot more for private insurance. We do have some more years now that we're trying to add. The difficulty was that we're using ICD-9 codes, and then from ICD-9 now there's ICD-10, and there had to be a crosswalk between the ICD-9s and the ICD-10s. They don't match up, so you can't tell. You can't just use them directly. So now that we have we should have more data. A lot of where you lose individuals is about continuous enrollment. So if I'm saying that an individual that I watched over 6 years didn't get screened, well, if they weren't in my system because they dropped out for a year and then they came back in, and I didn't see a screening, it may be not because they didn't get screened, it may be because they were in another state, or they changed insurance plans or something like that. So continuous enrollment is one of the things that really drops the count a lot. So then we use a statistical model where the outcome is whether or not a person had a screen, and then what type of screening they had. I think maybe the next slide will show it better. So yeah, it's a multi-level logistic regression where the first set is just whether or not they screened within the time window. The other set is conditional on their screening, which screening modality did they choose. And you'll see that we have individual level variables and county level variables. Why county level variables? Well, because we do know some things about the individual, like their race, the gender, the age, but for example, here's the kind of question about resources, the distance to endoscopy facility. We do know that because we do know their zip code. The problem is that we don't have a lot of the socioeconomic variables about the individual. They were either not asked or they were poorly recorded. So coming back to the, I think Luke asked about we didn't have the data. What did you do? We didn't have we didn't have their income. But what we did is we had. Yes, I'm so sorry. Go ahead.
You have 9 root mean square per 100,000. So if you take into account the perception of people is the chances of getting this cancer is very, very low.
No, that's the error.
All right, I didn't understand.
Yeah, I'm sorry.
What's the, given the people in the room, what's the probability that they will get this cancer?
It's still quite low. So let me show you.
That's one of the reasons why maybe people don't get this test.
Yeah, so that's a good point. So for example, the total cancer cases in 2014 were 68 out of 100 per 100,000.
Okay.
68 in 100,000 individuals in 2014 developed colorectal cancer in North Carolina.
So your perception that's low or high? I mean,
it is a low incidence event, but it's a very deadly cancer. So, but you get to a good point. Some of the interventions are about letting people know what the dangers is of getting the cancer.
Right.
Not just getting the cancer, but if you get the cancer, the mortality rate is quite high. That's the problem.
That's what I want to know.
Yeah.
That's the first thing I'd want to know.
Yeah, and some of the, and not in this paper, but in some of the interventions we're trying, we're talking about patient navigators. So basically, you're gonna get a phone call from a healthcare provider, kind of talking you through what the different procedure options are, and then also what the risks are associated with it.
Well,
So that's one of
they
the,
tell you the risks.
yes,
Because
so
my
that,
physician never told me the risks.
yeah, so there, in Oregon, we're trying that, and specific intervention. Yes, question?
What about like baking in family history into your model because it changes the guidelines and
Yes,
rules?
so this is for the population who is not at increased risk. The guidelines are different for people with increased risk. And actually, once you have a positive test, you become a person of increased risk, so we do have that surveillance built in there. So this is like for the general population, but that is a very good question. Yes?
Could you elaborate on what the risk, like what it entails? What is a person with a high risk of disease?
Either family history or if you have certain other diseases like some GI problems, you might be more likely to have colorectal cancer. But family history is the main one. Yeah. Yes.
You mentioned that there are increased incidences of people younger than 50. Like, could you talk about maybe what causes that would be?
I don't know specifically, but I do know that, for example, meat consumption is one of the things that is high. Not to say we should all be vegetarian. I eat meat, but like the amount of meat that we're eating has been increasing, and actually that's one of the potential things that could be. And just in general, we're exposed to a lot more carcinogens as well. So, but I haven't looked into exactly why now there's more cancers at a younger age. I think that's not just for colorectal cancer. It's kind of like an overall trend. I should stop more because you guys, it's a lot of questions on this. Okay, so we look at, since we don't have the income variable, we know it's important. We look at individuals' county, and inside the county, we look at basically some factors that were found to be significant. So, for example, the unemployment rate in the county, access was one of them. So there you have the test facility volume, like how many colonoscopies are, and so this at the beginning we actually had undergraduates calling to find out how many procedures they could do. So this is the procedural volume of the facilities in the county and things like that to take that into account. So from that we basically get the probability that somebody screens, and then if they screen, what they screen. But what we observed was a 6-year window of individuals, but a colonoscopy recommendation is over a 10-year window, and a FIT recommendation is every year. So we have to translate that into something that we're going to implement on a either 10-year or actually for colonoscopy, we give them a chance every 5 years because we found that people start to get tested around 45. And then for a FIT every 1 year. So we assume a binomial distribution for the number of screens in that time window, and we translate the cumulative 6-year distribution into a either annual or 5-year probability of screening. We also embed some other things like first-time screeners have an increased probability of being screened over those new to insurance, and this was found in the literature that if you sometimes people kind of hold off on going to the doctor, and then when they have insurance, they have all this pent-up demand, and then they're more likely to do things than they would like on the normal basis. So we build that in as well. But again, we're using this data is is not perfect. Someone mentioned, okay, we're ignoring family history, and it's claims data. So this is receipt of screen. Maybe I'm a millionaire and I just go and I, pay for whatever and I never turn in a claim. Or maybe I forget to turn in my claim and I ended up paying out of pocket for it. So the receipt of screen yields a much lower screening rate than what is observed when you look at longitudinal surveys where they actually ask people, right? So there are surveys, the behavioral risk factor surveillance surveys. This is a wealth of information if you haven't used it before. They ask people, have you gotten a colonoscopy in the last 10 years? Okay, so we have one where it's maybe underreported. What do you think happens when you ask people questions? Huh? So they overreport. Yes, you tend to be positive, overestimate. Maybe it was 12 years ago, but you don't think it's 12 years ago. It sounds like only 10 years ago. So you say, oh yeah, I did that, but maybe it was 12 years ago. So there's overreporting in the survey. What we do is we try to calibrate the percent up to date by bumping up the screening probabilities to match BRSS FSS, but we adjust for self-report. So there is also data that shows how people lie and how they overestimate, and it's differential by race and insurance type as well. So then we calibrate to that, and that fit is pretty good here. So like, for example, you can see, and actually screening rates have been going up, which is a good thing. So in 2012 in North Carolina, we were at the adjusted screening rates at 52% there, and so we calibrate to that. So we calibrate natural history, and we calibrate the up-to-date with screening. So I'll stop there, I guess, since I feel like I've been talking fast for a second. No questions? Yes.
Who is using, how do you validate the model and who is using the model? Because it looks like there are two components in your model. One is focused on patient, the other one is focused on how the patient is treated and what the system, the healthcare system is doing or not doing. So who is the user of that model?
So when we look at specific interventions, it is and even in this case, it's the CDC. The CDC to prioritize what interventions they might do in the state level. And the reason is that when you look at the evidence from small cohort studies where they try an intervention in one location, sometimes it works really well, and then they go try an intervention, the same intervention in a different location, and it doesn't work very well because the demography and the populations are different. So the CDC wanted to know in North Carolina what would work well. And in this case, in the previous paper, we show that even if you put in quite a bit of investment, you're not able to increase screening rates that much. And so this one was to look at something big like insurance expansion. Could that cause a difference? And the follow-on project that we have is basically taking a light version of this model that is much more user-friendly, and going to providers is more of an implementation science project. Going to providers and showing them what the impacts is of different interventions, hoping that they will be more likely to talk to, or community health workers, that they would be more likely to educate their own patients or community about it. So there's two users, one like the CDC at the policy level, and then the other is the individual providers or community health workers.
Yeah, but what is the role of CDC in forcing healthcare companies to do what they would require to do?
The CDC can't do that.
So nobody can do anything.
The government, the government can do that. No, it's more of like they can inform. They can write reports and they can inform. Right. The role of the CDC is to provide evidence-based information so that then the government can make better decisions. Yeah. But in the end, they don't have a mandate, except for the CDC does provide grants to states, And so they can use that to prioritize which grants they give out. So for example, one of the things they thought about was, could we create more facilities? Maybe there's not enough capacity, and that came out as being completely cost ineffective, and it was not one of the things that they decided to move forward with. Because of that. Yes.
But correct me if I'm wrong, the United States Public Health Task Force can also recommend certain recommendations for screening of CRC, right? And that's binding in some ways, like.
That drives what's paid for free. So that what the U.S. Preventative Services Task Force recommends is that you should get a colonoscopy every 10 years or a FIT every year. But they're not going to be the ones to pay for the interventions. So in Oregon, for example, we work with the accountable care organizations that manage Medicaid in the state, and they can use their funds to drive which interventions they use. Yes.
Do you consider the same or a stable distribution of the population along races across your time horizon? Or does that change over time?
Yeah, you mean, so people are aging into the system, so as much as the demography changes because of the aging effect, yes, but we don't take into account immigration. Yes. Yeah. I'm sorry, do we have a tissue? I have something. Okay, and I'm quite blind without my glasses, so. Okay, so the last component is now the intervention. So again, this one is about a big intervention. The previous paper, and I just was trying to present something newer, but I think you guys would be more interested in the evidence-based interventions. But so in this one, we look at what did happen, the status quo. That's what we were calibrating to, right? This is what happened in North Carolina is we had ACA, but without Medicaid expansion. The first thing is, what if we did have Medicaid expansion? So that means that we would increase the threshold for Medicaid eligibility for all residents to be 100%, 138% of the federal poverty level. And also, the other case is to recognize the value of the ACA by assuming that the ACA never did happen, so removing it. Okay, so the question is, if I have ACA or Medicaid expansion, how are people going to react to that? So how did the ACA actually change insurance uptake in North Carolina? And I put in Oregon here so you can see the difference. Oregon had Medicaid expansion. So again, remember these numbers are, so these are just health insurance coverage. Who has health insurance? So in North Carolina, in 2013, 20% of the people didn't have insurance. And with the ACA, that only dropped to 16%. And now we include 2015 because there was a lag a little bit, and more people became insured in 2015 as well. But look at what happened in Oregon. They were already more insured. They were already at, well, actually they're similar numbers, right? 20%, but then that dropped to 11% uninsured. So because they had Medicaid expansion, a lot more people got insurance. However, these who took up insurance was differential as well. So actually, younger people were more likely to take up insurance, and people sometimes didn't realize they qualified for Medicaid already, even before insurance expansion. But because when they went into the ACA, the health exchange, as soon as you enter your income information, it would tell you whether you qualified. So some people became that didn't know they were qualified as well. So what we do is we have data from BRFSS that looks at insurance in 2013 and 2014, and we model whether or not a person is likely to get insurance based on their gender, by age category, by race, by income category. We had a lot more information in the RFSS, so there you include marital status, right? If you're married, you might be more likely to have insurance. And then we looked at two-way interactions. For example, married women were a lot more likely to get insurance, race and income, and other things like that. So some of this data was missing. So another question about missing data, we used imputation on some of those variables as well that were important. Okay. So basically for each bucket of individual, like say a Hispanic female, age 35 to 44, who is married and a certain income category, what is the likelihood that that she would become insured? So we looked at the predicted probabilities of insurance in both 2013 and 2014, and then from that we calculate the conditional probability that a person in 2014 will get insurance given that they did not have insurance in 2013. So that is, now we can apply to each individual probabilistically whether or not they will, if they didn't already have insurance, if they were uninsured, whether or not they would get insurance through the ACA. And you know, it's not that everyone actually did get insurance once the ACA came into place. And if you're newly insured, you either get private insurance through the exchange or Medicaid if you qualify. And the Medicaid, we found that of people who qualify, that Medicaid uptake is quite high now in North Carolina. So, okay. So all of that I showed, all those things get dumped into this giant model to be able to answer the question, how has screening and outcomes changed following ACA expansion? Okay, oh, you don't want to know about the computer. Okay, we put it in a big computer, and then, well, here's the population. We basically looked at a cohort of people who would be age eligible for screen within a time window. So we're looking at anybody who is 50 to 75 between January 2014 and December 2023, and then follow them over the lifetime. So even though there are about 4 million people in that window, like if you took a slice on it on January 1st, 2014, this would be the distribution of the population. So so it's about 52% female, which is pretty much like the general U.S. population. But you know that so in North Carolina, you have a large Black population, a small Hispanic population, and then there's the age distribution. Oregon looks very different. If I were to show you the stats for Oregon. Okay, so we'll stop a little bit with the numbers. So first, cancer cases. Now this is over the lifetime. So back to your question, it says that if we didn't have ACA at all, we would have had 56,500 deaths due to cancer, and this many cancers diagnosed during that time. So you want to you want to actually diagnose more stage 1 cancers because they're less likely to lead to mortality. And you can see that it's a modest reduction, right? You go from 56.5 to 55.9. So you're only talking about 1,000 cancer cases averted. And then with expansion, you reduce that a little bit more by another 700 cancer cases. So the numbers are small because it's a low chance disease, but I don't know about you, but I wouldn't want to be one of those 1,000 extra people, right, that died due to cancer. And then if you look at the burden, we talked also about, I didn't put it here, but we have additional life years gained, because if you're diagnosed at an earlier stage rather than a later stage, then you have more life years gained. So I didn't put that here. So we see a reduction in total cancer cases and a redistribution of the cancer staging, so less cancers in the later stages. But it seems modest, and if you look at the screening rates, it makes sense. So if you look with no ACA, what the screening rates would have been, and if you look with ACA, they're small, right? An additional only percentage point increase in percent of individuals up to date. So you have only an overall 1% increase of individuals up to date with Medicaid and then with Medicaid expansion. But you see that the increase is differential, right? So some of the populations that already had a low screening rate are able to get a higher gain on the screening rates so for example, for Blacks, we have a higher increase and they already had a lower one, so it's kind of closing the gap on that screening disparity. You might say, well, it's only small, and I didn't put the half-wits or anything in here, but it's a very large population, and we run multiple replications, so the half-wits are quite tight around it. So you might say, well, there's a few cancer cases averted, and okay, it's a good thing, but it's a small impact. So if you were playing devil's advocate, you should say, well, yeah, that's all good, but this comes at a cost, right? Who's gonna pay for all of this? Because people are getting screened more, who's gonna pay for all of this? So in this, we costed it to include routine, like everything. We added the screening test, the diagnostic test, treatment complications. For example, a colonoscopy can potentially lead to bleeding and perforations, a small chance, but it can, and the treatment costs of cancer. So this is from a statewide perspective that we look at total costs. And what happens is that, of course, you have more people getting screened. So this is just the impact of Medicaid, of the ACA happening in 2014 and more people becoming insured, right? So you have more screens, and so you have more cost to the system. But in the end, because those individuals are getting cancer at earlier stages, which cost less to treat, then you end up with lower costs in the end, and it's hard to see if you would fill in the area here, but you do end up with a little bit of cost savings over the long term. Okay. And this is just assuming that the people that now have insurance and the newly insured, there should be some potentially like increased effect over time as more and more people become insured. Yes.
Were the costs of expansion included here? Because there's a state share in expansion. So I'm just wondering.
We just put all the costs.
So even paying for Medicaid enrollees.
Yes.
Their insurance.
Yes. Yes. In another, in the longer, more detailed version, I think you have the winter sim. We hope to write another paper where we're going to actually cost it out by Medicaid, Medicare, because part of it is the system is kind of a problem, right? You see the costs are early, so who's paying here? Medicaid. Who's getting all the benefit here? Medicare, because the benefits are seen when the person is older. So in another paper, we're going to cost it out by, and also private insurance gets the initial cost, and then all those people get on Medicare, and then the state gets all the gains. So why should the private insurance be worried about getting more people screened if they're going to be the ones to have to pay the cost in the beginning? So we will detail it out by insurer as well. That's a good question. Yeah.
So I have two questions. One is, isn't it an indication that the healthcare system is poorly designed because it doesn't appear to do anything?
Yeah, I try not to have political conversations.
No, I mean, isn't it a conclusion that you can draw from that? Or is it a valid conclusion that could be a criticism of the healthcare system? Not a political issue, but the system itself. And the other one is, how do you validate your model, your predictions?
So we validate the components of the model, meaning the natural history by calibrating to cancer incidence, so we're able to match the number of cancers that people develop in the state, and we also calibrate to the percent up to date. So even though we're modeling individuals' probability of screening, we're able to calibrate to the population level of percent up to date with screening. So we validate those two components. But since there is no ACA in one. Now in Oregon, they had insurance expansion, but we can't say what happened in Oregon is gonna happen in North Carolina because they're already very different states to start with. And the costing is real cost from the fees, so. Yeah.
And the costs are very different from one state to another.
Yes, well, the CMS costs, they have a rate that they will reimburse. But you're right that in clinic, like the treatment cost, those are pulled from like a meta-analysis that kind of pulls the costs of treatment sometimes. But the nice thing is we can easily change the cost and adapt the cost and, rerun the simulation model. So like you said, in Oregon, they do have different costs and we do run that differently. Yes?
I can't remember if you mentioned this, but does the model include the increase in the rate of people getting cancer? So, like as time goes on, the screenings will theoretically catch more because there'll be more people.
There are more people getting cancers now than in the 80s, but we're not building in, like, within a 10-year time window that more people are getting cancer because we don't have any data to support that.
Okay.
Yeah. So, it's a conservative estimate, and it doesn't say it here, but in the paper, and this is consistent. It is really hard to get people to increase their screening if you just are using the current methods, and the gains are quite modest. The good thing is that the increase in health coverage was also found to reduce racial disparities in screening because some of the issues were related to income or other social determinants. So even though they are modest, if you look at other literature, it's commensurate to what we find when we put other statewide interventions in place. I think we did mass media and some other things in the previous paper.
Do you have any data on what you can classify as you use the polys or
Qualies?
Yeah.
Yeah, we try not to use qualies. What we have is years of life gain.
Because it's not, it's cancer, colorectal cancer, once a year is something called.
Well, there's not a consensus of what the quality should be, and it should be differential by age and race, and there wasn't good data on that, but we could incorporate that. Right now, we were, not in this paper, but we do look at years of life gained, or cancer-free years gained.
And
Yeah.
the interventions like a massive, like how expensive were those relative to just increase, like, because you're talking, like, I know most of the time when they do colorectal cancer, just see such modest returns, and most of them were just educational, so were they very expensive, like in the grand scheme of things?
The interventions?
Like the mass media for cancer screenings and stuff like that.
I think we were trying to keep things at around $5 million, so not very expensive. Actually, I think that brings, I'll go back to this slide, but at the round table, one of the ladies from the American Cancer Society is, what the goal is? The goal is 80% to be up to date. That's the goal. They keep changing. This was by 2018. We're not there, right? So they'll have to modify the goal, and then 2020 it'll probably be like 70% and we'll still not be there. So basically, the realization that to achieve these goals, you have to do it all. And maybe patient education is one of those things that can be tested. So but that's what we're working with right now. So in Oregon, in addition to looking at what happened due to insurance expansion, we're doing evidence-based interventions, and right now we're focusing on Medicaid. So over there for Medicaid, they have, they call them coordinated care organizations. So every Medicaid patient is tied to a coordinated care organization. And they have incentives. One of their measures is the percentage of people who are up to date. So they've been trying a whole lot of different things, which is great because we get data on, well, what this intervention did for this group of people. So we're gonna be able to try things like direct mail. So I told you the fit kit you can do at home. Maybe you hadn't thought about it, but maybe if you get it in the mail and it has a free return envelope or box, then you would be likely to do it and return it. Or then maybe if you get it in the mail and then somebody calls you and says, hey, I haven't received that from you yet, would you be more likely to do it? So that's what the direct mail, there's direct mail with reminders. There's patient navigators where the person will call and instead of just asking them to get a fit kit, they would educate the patient on the different options and also on where they could get them. They even make the appointment for them. So like trying to get more at the patient level to increase compliance. And I mentioned that we are looking at patient choice and that the people in public health say, oh, there's colonoscopy people and there's fit people. Like you're just one or the other. So you just need to model which one you are and then your compliance rate. But we actually look at the claim data and we see that some people they switch back and forth. Their timing is not every year, every 5 years. Rachel Townsley, who just graduated, she looked at a model that takes into account past history of screenings in order to predict your future history of screening. Again, the data becomes a limitation because if I want, I could take that into account, but then I have to drop some of the demographic variables that are important to be able to have a large sample size. So it's kind of this trade-off between, until we get more data, can we take into account history or demographics? We need more data to take into account both. So those are some of the things that we're working on. I think I skipped. Yeah, I think we already talked about that. So yeah, so the questions. You all have been asking great questions, and they allude to this fact, right? You all have maybe seen this model, the social determinants of health model, right? So the problem is quite complex. You have an individual that's making behavioral decisions, but it's impacted both by who they are, but also their family and their community network, their living and working conditions. I don't have a car, I can't get to the doctor, and other things like the structure of our healthcare system in the US is all the way up here. So all of those things are driving my individual behavior that's going to drive my outcomes. And so I think that colorectal cancer is one of those things that they haven't really been able to figure out how to impact people's screening behavior well enough to reach our targets of 80% screening. So I think that's the last slide related to CRC. Yeah.
How sensitive your model is to different assumptions that you're making as far as the natural history or cause mortality? Did you find that some models are sensitive to sensitivity?
We do sensitivity analysis to some of the things that we estimate without a lot of data. Like for example, we can look at that % increase in additional screening associated with being a new customer, or in some of these evidence-based interventions, there's an effect size that is estimated based on a previous study. So we can look at the sensitivity analysis of, okay, maybe this population is not gonna react in the same way that another did. But to the specific example we gave,
Like natural history.
Natural history, well, because we calibrate to the natural history instead of doing a sensitivity analysis to that. Yeah.
The question, John.
Like, so how did you do like the geospatial stuff, like a little detail on that? So you just talked about like it was like a new curve, but like how do you implement that in model? Like just people would be left farther away, be left like maybe a big screen, like that.
So the distance to the endoscopy facility, we basically looked at the center of the zip code and then at the zip code of the nearest endoscopy facility and took that distance.
Just a straight line distance.
I don't remember if we used straight line distance or driving distance. And then the other way was because of where they were located, what the number of, what the capacity was, the procedures that were able to be done at the facilities where they're located.
And then I was kind of another question on facilities, was there a large disparity in like places like, just based on like the reputation or like here's a big hospital system, right? Compared to like other places in North Carolina, just the disparity in rates just because of like.
Well, I just looked at the claims data. I didn't look at where they were having that, just whether it was an urban area, a rural area, for example, or the zip code of the individual, not necessarily of where they were going. But that's so in Oregon, where they have this coordinated care organization, where individuals are assigned to healthcare, there is a huge disparity within this, with the CCOs, which are the medical homes, based on where they're getting care. So yes.
It goes into the insurance networks,
Yes.
Right here, a network that doesn't have a lot of capacity or doesn't promote screening.
Yeah. Yeah. Yeah, so in Oregon, we do have it at the CCO level.
Well, we have a small gift to thank you for traveling back to Michigan, and we hope you will travel to Michigan again. We'll have your princess.